On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Scaling the Mountain, Peaks and Pitfalls of Perioperative Pain Management. My name is Megan Shetterly, and I will be your moderator for this program. A copy of today's slides is available using the link provided in the chat box. The chat box can be found by clicking on the chat button in the lower right corner of your screen, and then you will see the chat bubble. The webinar will be available in a few weeks on the Patient Safety Authority's YouTube channel. We welcome any comments or questions. All materials are provided for your educational use. Now, I would like to introduce our speaker for the webinar. Dr. Tanya Yaritzky is a clinical pharmacy specialist in pain stewardship at the Hospital of the University of Pennsylvania, where she was also a founding member of the Palliative Care Service. She consults on patients with complex acute and chronic pain throughout the hospital and is vice chair of the Penn Medicine Opioid Task Force. She publishes and speaks nationally and internationally on pain and symptom management. She chairs the Society of Pain and Palliative Care's Opioid Stewardship Task Force. She was awarded Palliative Care Practitioner of the Year by Pain Week in 2015 and is the 2020 recipient of the Pennsylvania Society of Health System Pharmacists Joe E. Smith Award for Excellence in Practice and Service to the Community and Pharmacy Profession. Dr. Uritsky, I will now turn the program over to you.
Great, thank you so much. I'm really happy to be here and looking forward to talking to everybody today about the management of perioperative care for pain. So I'm going to jump right in because we have a whole lot to cover. All right, so here's our objectives for today. We're going to look at risk factors for opiate-induced respiratory depression in our hospitalized surgical patients. We're going to define opioid tolerance a couple of times, actually, and then we're going to look to recognize what other medications or central nervous system depressants will make opiate-induced depression and sedation, respiratory depression and sedation worse. And then hopefully we should be able to recommend an appropriate starting dose for an opiate-naive perioperative patient. I just disclosed that I did serve on an advisory board for ACIL-RX. So acute pain management. Acute pain is still a pretty significant clinical problem. We know that more than 80% of postoperative patients experience acute postoperative pain. 75% of patients with post-op pain report pain that is moderate or greater. So pretty significant severity in addition to incidence of pain. We also know that certain procedures are predictably associated with pain. We know that things like, total knee arthroplasty, total hip arthroplasty, open lap procedures of the abdomen, certain things are going to be very painful. And that, we do know that we would need opioids generally in some capacity to treat the severity of that pain. Pain is also the most common cause of readmissions after same-day surgeries. And so we do need to tackle this problem, which is why you guys are all here today. We're going to talk about JD throughout this presentation. JD is a 65-year-old man. He comes for a mediastinal mass excision. He does have a pretty significant history of obstructive sleep apnea, hyperlipidemia, hypertriglyceridemia, chronic kidney disease, anxiety, and chronic pain, which he had a motor vehicle accident in 2011. You can note his vitals there, nothing too crazy or out of whack. And then just also with his CKD, a note of his serum creatinine of 1.7. His home medications are here for your review. He does take duloxetine 60 milligrams daily, and just kind of focusing in on the ones for pain that would be impacting our pain regimen. He's on oxycodone 5 every 6 as needed, lorazepam 0.5 every 12 as needed, and he does have a PRN DocuState order. So our first polling question, which opioid regimen meets criteria to be considered opioid tolerant? Is it A, morphine 15 milligrams every 4 hours for 3 days, the same dose of morphine every 4 hours for 7 days, or morphine 5 milligrams every 4 hours for 3 days, or D, which is morphine 5 milligrams every 4 hours for 7 days? So if you go ahead and submit what you think is the right answer, we'll take a peek and see what you guys think in just a few seconds. You know, it's there's a lot to kind of think through here. So, you know, take your best guess if you're unsure, and we'll talk about kind of what the factors that go into opioid tolerance are as well. So I'll give you a few seconds to take that poll, and then we'll talk about the answers. Okay, so it looks like most people think that the correct answer is B. We have, you know, 20% of voters going with C, and then a small percentage with A or D. So I'm going to go with the majority here, and the definition of tolerance will help us define why that's the correct answer. Really, we're looking at the number of milligrams, and so for morphine, it's 60 milligrams, and then for the amount of time, which is how many days. So typically, the definition will be 7 days. So you'll see that on our next slide here, where, you know, there's opioids, and you can have an opioid prescribed and be taking some without being opioid tolerant. And then there's tolerance, which has a couple of different utilities. You know, we typically think of tolerance as you need more medication to get the same effect from the drug, so more medication to get that analgesic benefit over time because your body grows tolerant to it. But in this case, we're also just talking about whether or not the body is tolerant to it at all, you know, and so to define that, we use this middle ground here of opioid tolerance. And so you can see morphine 60 milligrams is what you need to have on board for 7 days to be considered an opioid tolerant patient. The other drugs are listed there for you, and I think usually people will be surprised when they see the hydromorphone 8. But, well, geez, that's actually not a whole lot if you think about giving someone hydromorphone 4 twice a day. So you can get the tolerance pretty quickly when you're talking about these things. And this is really important because this helps us figure out appropriate dosing to ensure pain efficacy, but also appropriate monitoring for safety. So when I talk about safety, I think our minds frequently jump to respiratory depression related to opioids. It's really important to remember that sedation comes before respiratory depression. So you're not going to just all of a sudden stop breathing. So you're going to become very sedated first. And there is a continuum of levels of consciousness. And ideally, we would be serially measuring for sedation because it is unpredictable how that's going to progress. We do know, though, that once you hit a certain threshold, you will begin to experience opiate-induced respiratory depression. And that's just, you know, the definition is there for you from the American Society of Pain Management Nursing, where it's a decrease in an individual's ventilatory function after receiving an opioid. We also know that the incidence of opiate-induced respiratory depression is low. It's actually 0.2 to 1%. But that's of all patients receiving opioids. So that does become much more significant when you think about that 80% of patients have severe pain after surgery type of thing. And not just that, but even if one patient experiences such an event, the morbidity and the mortality is so great that there is a large motivation to avoid these incidences. And just to talk for another few seconds about opiate-induced sedation, because it is so important. The greatest risk of sedation comes when you're starting a medication because you don't have tolerance to any of those effects yet. When you're titrating a dose, again, because you're now going above where the tolerance level is. And then with IV administration, largely because of that much higher peak of the medication with IV administration. We also know that the risk is increased when someone gets concomitant benzodiazepine or other CNS depressants. When I talk about this, I like to call out some of these other medications where we're typically trying to avoid opioids, and then we're giving patients cyclobenzaprine or gabapentin. We may be using diphenhydramine for nausea or for itching or for both. And so just thinking through that these medications, too, can increase the risk of sedation and advancing to respiratory depression. We know that opiate-induced sedation tolerance to this develops within 5 to 7 days. I'm sure, just like me, you all have seen patients on amounts of opioids that you can't understand how a patient is still breathing. Wow, that's a real lot of opioid. Well, obviously that's because the tolerance does develop. But once you layer in any of those other medications or a significant change in organ function or other clinical status changes, that becomes less safe, right? And we know that that's when somebody can jump into a bad zone with sedation and respiratory depression, despite having been on opioids for a long time. It's important to distinguish between fatigue and sedation, and I'll say that the best way to do this is probably using one of our scales, which I'll talk about here in just a second. And remembering that we do want to catch it. So using our scale to help us catch it before it advances is really essential. And if we do find that someone becomes sedated with opioids, lowering the dose is very critical. As far as our scales that I mentioned, two typically used scales are the RASS or the POS. So the RASS is the Richmond Agitation Sedation Scale. I'd just like to point out that while we use this in critical care very regularly, it's a highly effective scale. This scale was developed with the intent to monitor a goal-directed advancing sedation, so purposeful sedation. And we can modify this scale to be used with opioids. It does go from a 0 very quickly to trouble zone. So when you get yourself to a -1, you're already in a pretty bad spot. So it doesn't have a lot of wiggle room. And just be careful because it may be difficult to distinguish between pain and agitation and which intervention you need to treat. Another scale is the Patharo Opiate-Induced Sedation Scale, or the POS, and this scale is intended for specifically sedation due to opioid administration for pain management. It was found in the literature to be equal to the RASS for validity and reliability in our non-critically ill patients, and it was shown actually to be superior in ease of use, nursing confidence, and for usefulness in clinical decision-making in our non-critically ill as well. At our hospital, we actually have both scales being deployed. Most of our critical care units are sticking with the RASS because they're comfortable with that and they're very familiar. The POS is something that's generally been used on our regular floors because, as you'll see when I show you the scale here, it does provide some action related to the number. So if somebody is a 3 on the POS, where they're frequently drowsy, drifting off to sleep during conversation, I think we all can, think of instances where we've encountered patients at this level. Then it does say kind of what you can call the provider with and say, hey, look, my patient's at 3 on the POS. We should be doing what the directions here say to do. And it gives the nurse a little bit of power, and it empowers the nurse to speak to the provider with a recommendation and thinking about opioid sparing agents, et cetera, not just stopping the opioid, but what else can we give to still ensure analgesia. So we are using the scale a bit, and I think it has some really good aspects to it. And then, of course, when you do use scales to monitor, you want to document them. So this is just showing you, a screenshot real quick of what that would look like. And it is something that we have now defaulted into our vital signs monitoring when we're using pain medications. So this is all great to know and understand this, but really, what are the risk factors for opiate-induced respiratory depression? If you don't mind taking a minute, you can choose all that apply here. Options for other risk factors include obstructive sleep apnea, chronic lung disease, renal insufficiency, and concomitant sedative medications. I think it's important to note that a risk factor for opioid tolerance, for opiate-induced respiratory depression, is actually opioid tolerance. So we do reviews in the Naloxone administrations at our institution. And this is one of the most common attributes of a patient who has received Naloxone, is actually being defined as opioid tolerant. So that is why we do want to, one of the reasons why we do want to kind of know up front if a patient is opioid tolerant or opiate naive. That's why this is one of the ISMP recommendations for us to have that knowledge and information in front of us when making decisions. So it looks like, based on the polling results, everybody, almost 80% across the board, recognize all of these as risk factors for opiate-induced respiratory depression, which is great because they all are, right? So a change in any end organ function is going to lead to a risk for respiratory depression. And then we already belabored that common sedative medications. So what I have on the next slide for you is just like that really full list. And some of these are probably very familiar, like we all recognized on the last question. Some of these other things are things we just need to be very aware of as well. Prior history of naloxone administration is a big one. It may not be something we know about. When I'm reviewing our naloxone administrations, I have typed in the word naloxone and it goes anywhere in the chart and looks, and it's come up, and it was like 8 or 9 years ago. So I'm pretty sure the patient's not revealing that, and we may not know that. So that's a very important one to think about and make sure. That's why it's so important to document it when we have these events. But other things on there, like the first 24 hours of opioid therapy, post-operatively, and a prolonged surgery, as well as any kind of abdominal surgery, do put patients at risk. And so we did a performance improvement project at Hub, where I work, and we actually used this assessment so that we could help nurses identify patients who may be at higher risk for respiratory depression. This is the Michigan Opioid Safety Score. You can see it attributes a point for different variables that we already saw on that last slide. And then it does account for respiratory rate. It doesn't necessarily account for respiratory quality, but it does account for rate. And then it also uses the Patharo opiate-induced sedation scale to identify sedation. And accordingly, depending on what number the patient receives, you can see that you may stop or proceed with caution, or, it gives it a different, it helps kind of guide the care. And we found this a very effective bedside tool. The nurses felt empowered to speak with the providers about making changes, and we even had one patient who we were able to make changes on before they advanced beyond unsafe level of sedation. Other things you want to capture are things like hypercapnia. This is really controversial. I'm aware of that, given the limits of it, the discomfort of the actual apparatus, where patients need to be placed on a unit in order for monitoring, alarms going off when they're not appropriate, et cetera. So really, if patients hit those risk factors, and we're talking about typically patients need to hit 5 of the risk factors in order to be someone who would be defined as really high risk for potentially having an event. If they meet 5 of those risk factors, we should probably be thinking about, how we can keep this patient safe. If it's not hypercapnia monitoring, we should at least be doing more increased sedation monitoring and some of these other things like pulse ox. But pulse ox is going to also be late, right? So the oxygenation status is going to go down once the person's already in trouble. So while it's good and important to monitor, we do want to catch it before that starts to decrease, if possible. And then respiratory rate, depth, regularity, that's going to be important. Again, most of the time we're just capturing the rate and not the depth and the regularity. And then the heart rate as well. So this is all fine and dandy, but I have this nurse here saying, wait, when should we be monitoring all of these things? When is the right time? And that's me there, standing there kind of silly and saying, well, that depends on the pharmacokinetics of the drug. And really it does, right? It depends on the pharmacokinetics of the drug as well as what's going on with that patient clinically as to when we should be monitoring them. But it's also important to know if they're within that 24 hours post-op of increased risk. And so with those two things, we can decide when we should be monitoring. All right, so here, what does it depend on? Here's another question for you. Because we know we always monitor at baseline for pain. When is it most ideal to recheck your pain and sedation scores after you have administered an IV analgesic? So you can pull your answers on the side. Is it 5 minutes, 10 minutes, 20 minutes, or 30 minutes? And you might be kind of thinking to yourself, oh, well, they're all just minutes, and that just seems crazy. How could anybody do, a reassessment within minutes? And that is really one of the challenges that we're up against, is trying to complete these reassessments in a timely fashion, but also give us useful data, which isn't always that simple. We've found that to be pretty challenging, actually. So it looks like we've got the top answer here is 37% of folks saying 5 minutes, and not far behind that is 26% saying 30 minutes. So I'm actually going to go with a very different answer and say 10 minutes, and this is why. Hang on one second here. Okay. So This is not the prettiest visual. The next slide will give you the visual for us visual learners. But what this delineates is based off of the IV medication, the onset, the peak, and the duration. So you want to reassess, if possible, and this is why it's so hard, at the peak of the medication, right? Because that's why I actually titled this The Peaks and Pitfalls, because the peak is when you're not going to get any more analgesic benefit out of that drug, but you're also going to have the peak of your adverse effects as well when the drug is at its peak. So that's really somewhere between 10 and 15 minutes. That's also why we dose our PCAs with a 10 or 15-minute lockout. So because at that peak of the effect, if that patient's still in 10 out of 10 pain, theoretically they need another dose because they're getting no better analgesia out of that drug beyond that dose. So you can see also here of note, fentanyl is a little shorter. So if you were thinking IV fentanyl, 5 minutes is probably fair. You could go a little further out than that too. And then the duration, I think, is important to note, because what really gets my goat is when someone has an IV medication ordered every 4 hours as needed, because there's 2 hours where that person does not have access to analgesia unless you're giving them a scheduled backbone of non-opioids. Like if there's another approach to managing the pain and this is really just a backup, that makes sense. But if you're using that as your sole source of pain relief and the person has continuous pain, you're leaving them potentially vulnerable to untreated pain. Also, then you can look down to the oral medications and see that the peak of that medication is 60 minutes. So ideally, we reassess at 60 minutes after giving an oral medication. We find this to be very hard to do, right? As busy nurses, as bedside nurses with many patients to take care of. This is just very challenging. So that's why many of our policies call out a little bit longer interval to give folks time to get there. But it's, it has to be reasonable, but also an effective and safe consideration. So trying to strike the balance for what folks can do and should do. And then the things that can change the pharmacokinetics are important to think about too. So if someone does have, like you guys noted, the risk factors for respiratory depression, it's the same risk factors that are going to change the kinetics, right? So renal insufficiency, liver insufficiency, that's going to take longer for that kidney or that liver to, work that drug through. And so we may then push out to 20 or 30 minutes on peak because it's taking longer for the liver to metabolize it. So you could go further out if you did have some liver or renal insufficiency. This is that visual I was talking about as far as kinetics go. You can see the peak at the maximum plasma concentration there on the left-hand side is about 10 minutes, just plateauing somewhere between 10 and 15 and slowly wearing off over the course of that hour to 2 hours. So this hopefully just helps if all of those numbers were a little bit overwhelming for you. And then the thought is also about the agent. And I mentioned how fentanyl does have a little bit faster peak and, hydromorphone and morphine are a little bit longer. It's important to think about which agent we're selecting for patients as well, and when we're thinking about the kinetics. And, I could spend an hour talking about this, and I'm not going to. I'm going to make this brief, but I'm happy to answer more questions later. So morphine is obviously our gold standard. If we have renal insufficiency, probably not the best choice. If you gave your patient one single dose of morphine and they have CKD, it's okay, right? They'll clear it eventually. But if you give them multiple doses is where they start to accumulate, as well as if you give it an extended release. Hydromorphone tends to thought to be safer in our folks with renal dysfunction because its metabolites, while they exist, are less clinically significant. Still want to be super careful with those patients, though. It's also very potent, right? And we'll talk about that. At least where I work, the agent that we reach for a lot of times, I think because of how potent it is, the numbers, the dosing is a lot lower, although the strength is much higher. Fentanyl is a great fast-acting drug, fast on, fast off. When you're giving fentanyl in a regular scheduled pattern, or someone's on an infusion, or they're on it for multiple days, fentanyl does redistribute in the fat, and so it does kind of change the kinetics over time. But in the short term, it does wear off and on very quickly. That is why the transdermal patch works so well, because it accumulates in the fat, and so the kinetics of the patch are that it lasts longer as a result of that redistribution. Oxycodone, hydrocodone, or oral medications, not as much useful in that real acute periop period, but later on, right, when someone's tolerating our oral medications, I like to just point out in this situation, remembering that while these medications come in combo with acetaminophen, not always the ideal to give to our postoperative patients, because ideally we'd give acetaminophen on a schedule and then give the oxycodone as a kind of, if the acetaminophen and if the ibuprofen or other medications we're giving are not working well enough, then oxycodone is for that severe uncontrolled pain despite that. So taking the acetaminophen out gives us more utility in how we use our drugs. And I've included Tramadol, not because I love it, but because it is being used more often. And a lot of our early recovery after surgery protocols are using it, remembering that Tramadol is a very weak opioid and so really indicated for our moderate pain and not really our severe pain. So if we are using it for severe pain, we should be closely monitoring if we shouldn't be escalating to the next level. And then Methadone, just because it's important to mention, but really not an agent we're going to use post-operatively because of its very special kinetics. I love Methadone for pain. I have done palliative care for a long time before all of this, and we use that all the time. But in this setting, pretty unsafe to start unless somebody's on it at baseline or is maintained on it for opioid use disorder. All right, and so I did mention PCAs. We're going to put a lot of these medications in PCAs, and we just want to think about who is appropriate for a PCA. We're using less of these nowadays with our early recovery protocols, but still we are using them, and they are safe. I spoke about that 10 to 15-minute peak. That's what makes them safe, right? If you are at 10 to 15 minutes and you need another dose of opioid because your pain is so severely out of control, you can hit for that second dose, and likely what's going to happen is you're going to fall asleep. If you fall asleep and no one hits that button for you, you will wake up when you need another dose or when you're meant to wake up, and you will be fine. But if someone continues to hit that button while you're asleep, right, that's where you're going to run into trouble because it's no longer patient-controlled. So the beauty behind a PCA is the patient control. So when I think about the PCAs, I like to think about really who shouldn't have a PCA more than who should. And who really shouldn't are those patients who can't control the PCA, right? Either they're mentally unable to control it, so the anxiety or the use of controlling their pain is too overwhelming, or they're not awake, right? They're not awake enough. It's not safe. Someone else is likely to hit that button for them. Probably not the best PCA candidate. Anyone else with moderate to severe pain is probably an okay candidate. The pain has to last, generally more than 10 to 12 hours because then you should be admitting them to the hospital. But other than that, we just want to make sure that it's a safe intervention. And so the dosing is provided here for you in this chart. You can see the starting doses for morphine, hydromorphone, and fentanyl. And this is for opiate-naive patients. So typically we'll start about 1 milligram of morphine, 0.2 of hydromorphone, or 20 of fentanyl. If you have an older adult or a very frail, medically frail adult patient, you're going to want to start 50% of that, right? You're not going to want to start the whole dose because that could be too much for them. You can always, always go up. The first column there is the loading dose, and that is just intended to catch someone up, right? Because there's nothing worse than telling someone to hit a button every 10 minutes for an hour when they're in agony. That's tough to do. So this is intended to hopefully we can catch them up and then they can use that PCA as needed, hopefully not more than once or so, one dose or so on average an hour is kind of the goal. And of course, always documenting. Our PCA documentation is sometimes challenging to interpret in the chart. So this is an example of our protocol where we say that the nurse should be charting the shift clear at least every 12 hours and then assessing and documenting vitals, pain score, sedation at least every 4 hours. That's probably not frequently enough, but that's at least a place to start to make sure we have a regular check-in on the sedation and the pain and what's going on with the patient. And then ideally we would do this more frequently in the first 24 hours post-operatively. This is that chart I was referring to about equally analgesia. And the points I'll make here are that, remember, these are not starting doses, right? We would never think to start someone on 10 milligrams of IV morphine. I actually called a physician back in the early days of my practice and suggested a 10 milligram IV morphine dose. And he was like, are you trying to kill my patient? So that number 10 does scare people, which maybe that's a good thing so that we don't start there. But remembering that 10 of IV morphine is 1.5 of IV hydromorphone. And so I know there would be less hesitancy in starting 1.5 of IV hydromorphone because it just sounds lower, right? It sounds safer. Remembering that's still a whole lot of drug to give somebody. And so this is kind of remembering just our relative potencies, not our starting doses. These doses actually all also come from studies of single doses in healthy adults, really. So not our chronic users, not people who are very sick. That's why we have to do our math, use these numbers as our guide. Remember, we dose reduce for incomplete cross tolerance, and that if something seems too high, it probably is. So it's a good idea to recheck, to check with someone else. And remembering, you can always go lower and give more. It's awfully hard to take away if you've already given too much, right? So I'm always like, if you're unsure, give the 0.2 and reassess in 10 minutes and give 0.2 more. That feels safer than just giving too much if we're unsure. And again, I've provided here for you that tolerance dose, because it's just important to remember how that's defined relative to the relative potencies in the chart. All right, so back to our patient. Now he's here for surgery, and you're doing a pre-op chart review, and you see that he's got significant pain on admission. When interviewing him, it's 8 out of 10. He's really worried about his pain postoperatively. In addition to reassuring him, what should you tell JD about his pain postoperatively? Should you tell him he will not have severe pain? He will have severe pain, and it will go away with pain medications. He will have severe pain. The pain medications will lower it. Or he will not have severe pain. It couldn't possibly be worse than how it is now. And this goes into the setting expectations talk, which we'll talk about here for just a minute or two after this with patients. But, you know, we kind of got ourselves into this opioid crisis nest, some bit around having some expectations that maybe weren't realistic. And so if we can help patients understand what will be happening postoperatively and come up with a plan that works for all of us, oh, look, you guys are so smart, then we will pick C. He will have severe pain and the pain medications will lower it. So you guys are definitely listening to what's going on, and that would definitely be the right answer, right? It will go away, just won't work. And my God, can you imagine telling somebody it couldn't possibly be worse than it is now? So good job. You guys are very smart. Other things you want to do around setting expectations is setting norms, so kind of setting it as a normal, because what other people do or how kind of other people have received this and how we typically would prescribe our opioids, really focusing on non-opioids, around the clock non-opioids, and sprinkling in those stronger pain pills as needed, the appropriate use, and not necessarily treating sleep or treating anxiety, and kind of just making sure that the pain indication is hammered home. Monitoring for adverse effects, how to manage them, because nothing's scarier than taking a medication and being unsure if something's going wrong and what it's from. And then disposal. I think this is really key, right? Because even when we lower our opioid prescribing, we find that we still have pills left over, even if it's one or two. Patients need to know how to dispose of these things, keep their children and loved ones safe, and how to manage that. So this is a key part of the expectations. And perhaps this part of the expectations needs to happen at discharge, and again at follow-up when they are going to see providers outpatient postoperatively. Back to JD. So JD is in the PACU and having severe pain despite getting hydromorphone boluses of 0.2 milligrams every 10 minutes times 3. His provider is ordering a PCA with a 0.2 milligram an hour basal, 0.2 demand, and a 10-minute lockout, and his 4-hour maximum limit is 4 milligrams. Does this seem appropriate to you? So the first is yes, because he's opiate naive, and the starting dose is 0.2. Yes, he is opioid tolerant, and he should have a basal. No, JD is opiate naive, he should not have a basal. Or no, JD is opioid tolerant, and the appropriate hydromorphone starting dose is 0.4 milligrams. So I think we're asking you to look at his state of tolerance as well as the appropriateness of his dosing on his PCA kind of at the same time. So a little bit of a compound question. Hopefully we don't trip anybody up with this question. And so in the results, the most common answer is JD is opioid tolerant, and he should have a basal on his PCA. So let's think back to JD. JD is on 5 milligrams of oxycodone. I probably should have given you that. He's on 5 milligrams of oxycodone every 6 hours as needed. So if we do the math, that's 20 of oxy or 30 of morphine, which actually makes him not opioid tolerant if he's taking it as prescribed. I'm suspicious he might be taking it as more than prescribed. But in theory, based on his opiate naivety status, he is opiate naive. And so technically, he probably shouldn't have a basal on his PCA. But with that amount of pain he's having, we probably need to think about our dosing, right? For sure. So let's talk about that. So now that we've got him in the situation where we've given him a PCA and he still has uncontrolled pain, and we dosed it, it looks like here, according to the case, hydromorphone 0.2 every 10 minutes, but a lot better every 10 minutes. And he has duloxetine 60, which is a home med, acetaminophen scheduled, and gabapentin 300 twice a day. With him having these medications on board, the question is, which is not a polling question, it's more for thought, is how do you recommend to titrate his medications? So he has some room to go on his gabapentin, right? But he's in 10 out of 10 pain right now, acutely post-op, and I'm pretty sure going to 600 BID or 300 Q8 isn't going to cut it. As CKD, so I imagine that's why we're not giving a non-steroidal to this guy. So I think that we're pretty much in a place where we need to think about maybe he was taking more oxycodone than he was admitting to, and let's say he was taking 2 potentially every 6 hours or taking it every 4 hours, where he got himself into a little bit more of a tolerant state than we would have thought. So I think I would increase his PCA, and the question I would get is how? How much? Where do I go? So you want to make increases at the peak effect, right? Like that's why we have PCAs dosed that way. If we know if that pain is 10 out of 10 despite the peak of that drug, well, it's just not enough drug. We want to use the smallest dose that provides the greatest relief with the fewest side effects. Of course, that's the goal for everything, right? So in this instance, the general recommendation is to titrate 25 to 50% for mild to moderate pain and 50 to 100% for moderate to severe pain. So when we're starting when we're thinking about this situation, you're safe always somewhere at 50%, right? That seems pretty safe. So a 50% increase would be a reasonable thing to think about. And then if we were going to go and start a long-acting, let's say on him, which we're not, but let's say we were, we'd start 50% of the total use on that PCA, and then provide our oral breakthrough every 4 to 6 hours. So just kind of 50% is pretty safe rule of thumb a lot of the time. And then you have to at least titrate by 25% because anything less than that, you're not really going to feel. So if I only went up by 10%, I'm probably not going to get much analgesic benefit. So that's just a note. And then we want to optimize our non-opiate analgesics as much as possible. So could we titrate his gabapentin? Sure. I'm not that excited about the fact that he has all those risk factors for respiratory depression in addition to needing opioids, and the minimal benefit we're probably going to get from that. So I think I'd optimize, at least try to up-titrate his opioid, and then also think about how I can move on that gabapentin if I need to. And so speaking of gabapentin, we're going to have a party here. We're going to invite all of our friends, and so we need all of our multimodal analgesia. This term gets thrown around a lot. Multimodal analgesia does provide a way to achieve balanced, safer pain therapy. It includes all of these things, right? It includes our regional anesthesia with our local anesthetics, our blocks, in addition to our medications, IV, oral, topical, really hitting it home from different places. And so you can see from this image that these agents work in different sites peripherally. The medications listed there work in the periphery, so they can target some of the peripheral pain. And then when you get across into the spinal cord and look up into the central processing of pain, you can see that different medications work there, although there is some overlap. And again, the descending modulation, how that might be treated with different medications. Again, there is some overlap. So picking from different categories of medications helps us to target the different pathways of pain, and that results in improved quality of analgesia, fewer adverse effects, and a better functional status overall, because we're needing lower doses of individual medications and not needing to titrate very high. Our adverse effects tend to be lower. This is highly distinct from polypharmacy, remembering that polypharmacy is when you're kind of starting a medication and treating an adverse effect of that medication with another medication. This is really a very intentional, rational polypharmacy, and we'll talk some more about some of these drugs so that you can have an idea of where we're going. So I already talked about acetaminophen. This is a way to keep the opioid dose down. It's a way, it has to be scheduled because remember that if it's written PRN mild pain and the patient's pain is always 7, it's never indicated, right? So it really needs to be scheduled so the patient gets it. Same thing with nonsteroidals. If it's written PRN moderate pain and the patient's pain is always an 8, they're never seeing that nonsteroidal. So we need to make sure that these are on a schedule as the backbone of our analgesia. A lot of times we're giving these preoperatively, something like celecoxib in addition to acetaminophen. Acetaminophen IV or PO is equally effective. If someone can get PO acetaminophen, they should get PO acetaminophen. While the peak of IV acetaminophen is greater, it has not been correlated to greater analgesia. So if a patient needs IV because they can't take PO, that totally makes sense and it's fine. But if they can take oral, they should really take oral. The cost of IV is significantly greater and the burden on the nurse of administration as well. So just some things to think about there. As far as our NSAIDs go, I think we know our adverse effects and thinking about when we can use them topically as well to help decrease those adverse effects, especially in our more vulnerable adults, what is also helpful. Anti-convulsants like gabapentin, pregabalin, those medications, again, associated with sedation. So we want to give them, in a fixed dose, usually pre-op and maybe for a short-term post-op, but not necessarily long. They don't need to be continued beyond the perioperative period, typically. And topical lidocaine is a great medication for local pain, not for pain that's more diffuse. And remembering not to cover it with heat and that it really has to go on the site of the pain, not like next to the wound or anything like that. Typically doesn't work that well that way. Antidepressants are getting a little bit more data now in postoperative pain. Duloxetine has some more data saying that it may be helpful. If you're looking at using antidepressants, it's good to talk to the patient about that because sometimes patients have strong feelings about antidepressants, but really talk about the intent and what we're trying to do is treat the pain. Our tricyclic antidepressants are typically not as well tolerated, so we're going to reserve those as last line and lean more on our duloxetine. Our venlafaxine needs to be titrated up to that dose you see there, and so 150 to 225 milligrams is hard to get to in a peri-op period, so probably not the utility in that period with that medication. Cannabis is a hot topic, right? And so I think the most important thing with cannabis is we usually aren't continuing this in the hospital for lots of different reasons. And that's where the pre-op screening needs to happen. If a patient is using this preoperatively, we need to try and get them to stop and taper it off before surgery so that they're not having acute withdrawal when they are in the hospital. So this question is important to me to ask about that holistic care and pre-op and assess for cannabis use. While it may be treating their pain, it's going to make it very challenging post-operatively. Other things we can do intra-op or acutely post-op is lidocaine and ketamine. Non-pharm, I'm not going to spend long here, but this is actually a very important part of all of the pain management. There's lots of options. Patients are typically the primary barrier here. They need education, right? Why this is important, how this complements what the medications are doing for them, and engaging specialists in this who can help provide the education as well is really important. So consulting your physical therapist to explain why movement, even though it hurts, is the right thing, for example. When thinking about what to reach for, we do need to think about our pain assessments. Just quickly, this is the modality that I use to assess pain, PQRSTU. Very easy because it's the alphabet. And so P is typically precipitating or palliating, what makes it better, what makes it worse. Q is your quality. What does it feel like? Burning, stinging, stabbing, shooting. Can tell me what kind of pain I'm targeting, right? If I know that a nerve was snipped to get to the site of surgical intervention, they're probably going to have some nerve damage and have some neuropathic pain, and it might be burning. R is radiating or release. Does it radiate anywhere? What do you get release with if you didn't ask about palliating? Site or severity is S. Severity, we're going to talk about here for a minute. Site, I think, is obvious. And T is timing. It's temporarily worse at night, during the day, with movement, et cetera. And then U is how it affects you, quite possibly the most important part of the assessment, right? How does it affect you as a person? What can you do? What can't you do? What about your mood? What about your being able to see your grandchildren? What are your goals? How are the medicines affecting you from an adverse effect profile? This is really what we need to get out, right? We think we spent a lot of time in the past talking about severity, 1 to 10, 0 to 10, what's the severity, right? And that scale is so hard because who doesn't say 7? I don't know, I think it's 7, I think it's 5. Like it's kind of really arbitrary. And so we can use different scales that help us keep on a functional pattern. The most important thing, because we do have to use the scale when we're documenting, is to remember to ask if someone does say their pain is a 7, is that tolerable for you? If it's not, do you know what number would be tolerable for you? Can you tell me? If they say 0, then that's an opportunity for a conversation to discuss realistic expectations. So just using that scale as a modality to talk more about what we think we can achieve. And then keeping in mind that together with that scale, this is what goes into it. So patient sensory or discriminatory property of pain is just that, how they perceive the experience of the pain physically. But then motivational affective is actually the emotional part of it, right? What it means to them emotionally, how they're responding to it, how the anxiety is impacting it. And then cognitive is what it means. So if you just had surgery and you know it's going to get better, cognitively it's different than if you just got diagnosed with cancer and you're like, this is only going to get worse. And so I think, trying to get at the meaning of the pain can really help with the spiritual part of it, with assessing who can help support this patient. And altogether, unremitting pain does affect all aspects of quality of life. So assessing these things and attacking them from different ways beyond medicines is also very helpful. This is one of those scales that helps us get at the function. So this is from the Defense and Veterans Pain Rating Scale, and this incorporates the FACES scale, which you've probably seen before, together with the number scale, and gives it words as well. So no matter how you learn or how you report, you have words, you have numbers, you have faces. You can see that it helps somebody understand that 10 is as bad as it could be, nothing in the world, I can't even think about anything else, versus 1 is like, okay, I'm all right. So this helps put it in perspective. And then it also has this part of the scale, which talks more about how it interrupts your life and your quality of life. And it gives it, helps people to think through that spectrum of where it is during stress and sleep and activity. So let's take a second here and just talk about opiate-related adverse effects when we're talking about how the pain is affecting the patient. What adverse effects do you want to be sure to monitor for? And you can select more than one. Lots of times I think we kind of get hung up on certain ones, and then other times we don't realize what all of the adverse effects of opiates are and when they might start to occur. And so it's important, depending on what phase of care we're in, how we're going to monitor and what we should be monitoring for. And then I think it's interesting on what we are documenting on as well, because I think a lot of times patients have pruritus, but we don't really have a spot in the chart to document that. So it can be helpful to kind of think through what the possible adverse effects might be. And so it looks like most people are picking the top 4, mostly constipation, sedation, confusion, lesser pruritus, but still 67%, and then 7% say immunosuppression. And I think you've kind of got it right. So immunosuppression is important. It's more important in the chronic use of opioids. If you have somebody on chronic opioids, they are at risk for immunosuppression from being on chronic opioids. And so that would be a conversation for long-term use. These others would be definitely more short-term use. And quickly, we'll just touch on this. I'm not going to belabor or go through this. I just want to present this information for constipation management. So we know that we definitely need a stimulant. So when you look at this chart and you see context stimulants, Senna is going to be one of your best friends, right? This patient here is only on Colate, so Docusate, PRN. That's not a good bowel regimen. We want to make sure he has Senna, and we want to make sure it's on a schedule. Another great agent to think about is magnesium hydroxide. The reason I'm pointing these two out is because they act quickly. So if you have someone who is really backed up or hasn't gone in a while, these are going to be medications that are going to act quickly and can be redosed fairly quickly as well without dose stacking and explosive-like responses. Miralax or polyethylene glycol is also really great if you're not looking for that very rapid effect, but you're looking for something that is softening and stimulating. This is just good to know kind of how these things work and where. And then the other adverse effect I like to point out when we're treating with opioids, especially post-operatively, is pruritus. Up to 50% of patients will experience this. I know I experienced it when I had an epidural, and it was really wild, and no amount of Benadryl was going to make it go away. And so the most likely mechanism for this is through the central mu opioid receptor. Histamine release is part of it, but we know that opiate-induced pruritus is mostly due to that mu receptor. And so we should be treating with things like nalbuphine, which is on shortage, or low-dose IV naloxone. Antihistamines are great, except, again, they're sedating, and they're probably just making you sleepy so that you're not itchy more than treating the itching in and of itself. So if you have access to low-dose IV naloxone or nalbuphine, that's probably a better intervention. And then if none of that works, you can always consider opioid rotation. Okay, so then cray-cray, because he's now going home. That happened so fast. He's post-op day 4. His pain is controlled on Oxy-10, Q4 as needed, gabapentin, duloxetine, and acetaminophen. We need to send him home with medications, but which ones and how much? So this gets tricky, right? There are guidelines in acute surgical pain. It's about managing expectations, maximizing non-opioids, avoiding opioids for minor surgical procedures, limiting duration of opioids, typically to 5 to 7 days post-operatively, and then disposing appropriately of opioids as well to prevent misuse and diversion. I like to present a birthday cake. Really, maybe the opioids can be viewed as party favors. So in one study, there was 2,392 patients studied. Of the opiates that were prescribed, 27% were consumed. If patients were prescribed more pills, for every one pill they were prescribed, they took 0.53 additional pills. So they were taking more medication the more they were prescribed, and that was significant. And then 58% of pills were remaining, which is about 42,692 pills, and 18% of patients received disposal education. So all of those pills were floating out there, but most patients weren't told how to get rid of them. I think that's really important to set us up for some of our prescribing guidelines. These guidelines are intended to help right-size, not undercut, but right-size opioid prescribing. They're evidence-based off of lots of literature. This is the Pennsylvania Opioid Prescribing Guidelines, and you can see the recommendation kind of range for prescribing of opioids dependent on surgery. You can look at the website if you want more information on which surgeries they've defined as major and minor, because they do have that clarified as well. You can also look at the amount a patient has taken before discharge, and based on the post-op day and the pills they take and the pills they've taken in-house, you can decide how many pills they will likely need at home. This covers about 80% of all patients. So if a patient is not taking any, they probably don't need any after post-op day 1. If they're discharged on post-op day 1, you should give 15. If they're discharged on post-op day 2, somewhere between 15 and 30, depending on how many they're taking in-house. So 5 to 10% of opiate patients will become chronic users if they're given longer day supplies, like 8 or more. There's a 13% chance of being on opiates at 1 year compared to a 6% chance for a smaller prescription. For JD, he's going to go home. You review his medication before discharge. You find he's taken 4 doses of oxycodone. He's working with PT. His pain is a 5 to 6 and rated as tolerable. He's given a prescription for Oxy-10, number 30, and you note this milligram equivalent of morphine is 90. Is this an appropriate discharge prescription for JD? Yes or no? And I think the next question is JD a candidate for naloxone co-prescribing, which I think is also an interesting question that we'll talk about here in a minute. But typically we think about the MMEs of a prescription, but also about how much he's taken. So if you remember, he was post-op day 4, and he's taken 4 doses of oxycodone. So the recommendation from the previous slide was, I believe, somewhere around 30 pills. So it's not unreasonable to send him with 30 pills, but I would send him with a naloxone co-prescription because his MME is over 50, and he has COPD, he's got a whole bunch of risk factors, CKD, OSA, right, chronic pain, he's co-prescribed benzo, so all kinds of risk factors that I would say this man probably needs a small supply of oxycodone here, but he also needs to be kept safe. Thinking quickly about naloxone, there is a standing order in Pennsylvania, but we also have in our institution a BPA that flags to providers when someone is receiving more than 50 MEDD or getting co-prescribed a benzodiazepine. You can get more information on education for naloxone at the places here in this box. It's important when we're talking about naloxone as part of a universal precaution to remember to destigmatize it, right? It's really an extinguisher. It's only there if you need it. It's like a fire extinguisher for your house. You pray you never have a fire, but if you do, you want that extinguisher there. Same thing, if you are going home with insulin, you'd want to have some glucagon. It's best practice. These are other best practices when we're prescribing opioids, usually not as much perioperatively, but if this is going to be maintained long-term, we need to make sure that we have these things in place. So our patient goes home on these medications, as we outlined before, and education is provided on medication management, safe storage and disposal, naloxone, and tapering. So speaking about tapering, just thinking about the duration of therapy. If this man has been on therapy for years, we need to go slowly, right? If this man has been on therapy for days, we can move much faster. There's a psychological and a physical component that we need to account for here. And so, if they're somewhere in between, you can adjust the taper faster or slower. But this is just good recommendations. And remembering it's reducing by 20 to 50% of the initial amount, not of each amount as you go along, or you'll be doing it forever. And so in summary, opiates are high-risk medications. It's important to talk about them that way. The patient's not the risk, right? It's the medication that puts the patient at risk. We need standardized approaches, universal precaution, and education around safe opioid use. Opiates are the icing on the birthday cake, not the batter, right? We want a backbone of our non-opioids and our good pain best practices, and that consists of multimodal analgesia, as well as screening our patients to keep them safe and monitoring, especially during that first 24 hours post-operatively, and keeping an even closer eye on our high-risk patients, and engaging patients in discussion of risks and benefits and expectations will really help improve the safe use of opioids. That brings us to our final finale. What questions do you have?
Thanks, Dr. Yaritzky. This is Megan Shetterly. That concludes the slide presentation portion of our program. That was awesome. We would like to begin our question and answer period. If you have questions, please type them in the Q&A box. There's a chat box and a Q&A box. If you could put those in the Q&A box down at the bottom of your screen, and please click on the 3 dots and then click Q&A to open the Q&A panel, and then direct your questions to all panelists. And we're going to try to answer as many questions as we can. I do see that there are actually 2 questions in there right now, Dr. Yaritzky. The first one is, why is prior administration of naloxone a risk factor for OIRD?
So having had to receive naloxone in the past means you had some other risk factors already. You already kind of had that exposure and that experience. That means you're kind of predisposed. And so the literature shows that if you have received naloxone in the past, you are much more likely to have to get it again. And when we were looking at our patients at HUP, we found that that was definitely true. And I guess that I searched and I had to go back really far, and I found some of the patients had actually received naloxone in the past, and we wouldn't have even known it. So because just of the nature of the game, unless it was some really crazy thing that happened where you were massively overdosed by accident, if it was just standard care, then you're at higher risk again every time that you represent. Okay.
There's another question here. It said, what is the EBP for the first 24-hour post-op pulse oximetry monitoring, continuous versus intermittent?
Yeah, continuous would be preferred, especially if it's a high-risk patient in that 24 hours, just because intermittent might miss an opportunity. And you can't see the trends, too, which would be ideal as well when you're giving opioids.
Right. Okay, great. Thank you. And, I have another question here. If a patient, I think you may have covered this, but if a patient is high risk for opioid-induced respiratory depression, what do you recommend to keep this patient safe postoperatively?
So if they are high risk, I think that it's really important to have serial sedation monitoring. We're going through this at our hospital a bit now of what are the best practices and how, what can the hospital resource-wise do versus what should be done. And truly, if someone is truly high risk, meeting multiple risk factors, it would be ideal to have them on hypercapnic monitoring if possible. And that's not always possible, but at minimum, ensuring that we have continuous pulse oximetry. Patients ideally will be closer to the nurse's station, and then doing sedation monitoring at the peak effect of the drug if possible would be ideal. Again, peak effect is hard. I recognize that. But that would be the ideal situation. And you can also use tools like the MMOS, the MOS I showed, to kind of help identify the risk factors and use that together with the sedation to think through a patient's risk. Optimizing non-opioids versus escalating doses of opioids would also be really important.
Okay. And I think maybe just one more question. We might have opportunity here. One of our attendees has asked this question. We have looked at our post-operative management of orthopedic patients as they tend to receive much more morphine and Dilaudid. Are there any existing recommendations on immediate post-op pain management for these types of patients?
Yeah, so we have actually looked a bit at that too. And one of, and actually the co-chair of the task force, of the PEN task force with me, does a lot of work in this realm. And so they've come up with standardized order sets around scheduled NSAIDs, scheduled acetaminophen, gabapentin, the pre-op interventions as well with acetaminophen and using NSAIDs. So like they have basically an ERAS that they use, and then lots of non-pharm. I know a bunch of my colleagues use these water-based machines that can really help, basically like ice machines that can really help decrease pain in that acute post-op period. So optimizing all of the non-opioids and then working through kind of standardized order sets on ordering for opioids has really helped to kind of rein in the opioid use. I also think the biggest thing to tackle is the surgery itself, right? So working with the surgeons to see kind of if there are blocks, they can start to implement like local type of interventions to help decrease the need for opioids postoperatively. They're actually not even giving these patients PCAs anymore. They've been so successful. So. Yep,
I just noticed somebody did actually comment in the Q&A. They said we use a lot of nerve blocks for hips and knees with good results. So yeah.
Yeah.
Okay. Well, I think we're at our hour. Might even be a little bit over, but again, we appreciate your speaking for us today. A lot of really great information. This concludes our webinar. Thank you.